program. I'm a professor here. I have nothing to do with the fire alarm system. And I apologize for the inconvenience, but I don't think it was the university people who did this. Somebody's bright idea was to test the alarms when we have classes on the 3rd and 4th floor and 2 conferences on the 1st floor. So I'll try to find out on Monday who thought of this. I'm a neuroscientist, a PhD, so I am not a clinician, although I've been working. Yes? Can you hear me? Okay. Okay, I'm a neuroscientist. I'm not an MD, but I've been working with pain-related problems for the last 10 or 15 years. Most of them with Dr. Robert Schwartzman, who just retired in June of this year. So I'm going to try to, in lay terms, talk about the pathophysiology of CRPS, which is hard because we don't really know exactly the pathophysiology of CRPS. We know about the pathophysiology of neuropathic pain syndromes, of which CRPS belongs to. And one of the problems with CRPS, when the word complex is well placed, is that you can probably get to the diagnostic criteria many ways. So what you end up seeing is a mixed population of patients that have a common set of signs and symptoms that probably arrived at that there by multiple pathways, and different medications work for some and others work for others. So what I've been trying to do is trying to take this very large bucket and split it into individuals which have not only a common set of signs and symptoms, but they got their the same pathway and probably the same medications will work for them. Sometimes clinical trials fail because the drug will only work in a subset. And when you put in the placebo effect, the effectiveness of the drug is buried in the noise. So you may have a drug that will work on 20% of the CRPS patients, and you have a 10-15% placebo effect, and it gets buried in that noise, and they say, well, the drug didn't work. When in fact it did, but it only worked in some, not all. So the way to get around that is to come up with both clinical and biological criteria that can take a very complex set of signs and symptoms and break it up into subsets that may be amenable to one therapy or another. So you all know about pain. So pain probably has more than these, that, but I'll just quickly go over what we think of physiologic pain, inflammatory pain, and neuropathic. So physiologic pain is a normal pain. You step on a nail, somebody takes a ice pick and stabs you in the arm. That is physiologic pain. It's very amenable to opiates, and once the insult goes away and it heals, the pain goes away. So physiologic pain, if you get a little prick with a safety pin, it hurts a little. If it's a little more, it hurts a lot. You're not in constant pain. And non-painful stimulus do not cause pain. So if I rub your arm a little bit, you won't feel that. Okay. Inflammatory pain is a little bit different. It's more like if you have gout, your knee will hurt because uric acid crystals form inside your knee, and when you move, it's like sandpaper, and it gets inflamed, it gets red, it gets allodynic, which is somebody touches you, it may hurt. It gets hyperalgesic. A painful stimulus in a swollen joint is more painful than if the joint wasn't swollen. So, however, when the inflammation goes away, the pain goes away. So, in inflammatory pain, you may have a little bit of constant pain with no stimulus. A non-painful stimulus may be painful. Painful stimulus are more painful than they ought to be, and they perseverate a little bit. They don't just go away right away. And then we get to neuropathic. Neuropathic pain is pain that you feel because you have damage to your nervous system. You can damage to a nerve. People with MS that have demyelination in their spinal cord, if it's a sensory tract that's affected, they may end up with pain. Obviously, if it's like an optic tract that's affected, they have visual problems. So, if you have damage to the nervous system, due to an injury. And some of these injuries, like could be a spinal cord injury, where you cannot move below the level of the injury, you cannot feel normal feelings, but your legs are in pain. And there's nothing you can do. You know, an itch you can't scratch. The same way with phantom pain. You lose a limb, and you could end up with pain in the part of the limb that is not there. That's neuropathic. CRPS belongs to that category. There's damage to your nerve somewhere. Okay? And then there's a maladaptive response to the damage. It doesn't happen to everyone. If everybody who sprained their ankle got CRPS, it would be horrible. Most people just heal and the pain goes away. You break your wrist, you probably meet the criteria for CRPS for a few months. You know, you have a broken wrist and the area is red and it's swollen and it hurts. And if somebody pricks you with a pin before it heals, it'll hurt more than your other wrist. Okay? And it may be red and discolored, and if you go through the list of what CRPS is, you may need it, and slowly as you heal, it goes away. But a subset of individuals, the injury heals and the pain doesn't go away. And we don't know why. And we have some ideas, but we don't know why. So that's neuropathic. You're in pain with no stimulus. And non-painful stimulus gives you pain. And a painful stimulus gives you more pain than it ought to. And not only that, if the physician comes in with a safety pin and he pricks you in an area, not only will it hurt more, but after he removes it and he asks you 30 seconds later, does it still hurt? And you say, yeah. And you also don't have very good discrimination. You know, I pricked a normal person with a pin, and he felt it where the pin hit. You ask the CRPS patient, where does the pain? And they'll say, well, it's kind of around there. So how big? So, well, a quarter. So it didn't stay a prick. It went to a dime or a quarter or a silver dollar. It is bigger than, so you don't have good discrimination spatially of where you were hit with the safety. So that's neuropathic. And CRPS falls into that category. So they think of it, most people think of it as a damage to peripheral nerves that cause peripheral neuropathic pain. And there's lots of other things that do that. Post-herpetic neuralgia, chemotherapy. You have cancer, chemotherapeutic agents can damage your peripheral nerves and cause pain. You can have central neuropathic pain, spinal cord injuries, MS, fibromyalgia. Some people think that many of the features of fibromyalgia would fit in the neuropathic pain categories. I am sure that there are individuals who have fibromyalgia who meet the criteria for CRPS, and there's some CRPS patients who meet the criteria for fibromyalgia, and there's some that don't. So the first cousins, I don't know what cousins either, but they fall in the same large rubric. So CRPS, and I can actually see it here. So it's an array of conditions that has to meet a specific criteria. And the criteria are based on signs and symptoms. Now all the clinicians, and they call it a type 1 and a type 2. To myself and many other, a lot of the clinicians, it's a distinction without a difference. In one of them, you cannot demonstrate a nerve lesion, on the other one you can. But it's hard to get many of the features of CRPS without some nerve lesion. Just because you can't prove it with an EMG doesn't mean it's not there. So just for those who don't know what a sign and symptom is, and you all probably do, a symptom is something you notice. A sign is something the nurse or doctor who examines you notice. So if you see a rash on your hand and you go to your doctor and you say, I have a rash on my hand, that's a symptom. If he sees a rash on your hand, it's a sign. If the rash is gone, it is still a symptom. You felt that at one time. You just, on the visit, it wasn't there. Okay? He could also examine your back and notice that you have a rash there that you didn't see. That's a sign. You didn't call. So, essentially, the criteria for CRPS is a list of signs and symptoms. Something that you go to the physician and say, I had this at one time, or even have it right now, and then he'll look at the sign to see how many of those things he can see, or maybe others that you missed. So this is the menu for having CRPS. Okay, so it's continuing pain that is disproportionate to the inciting event. You must have at least one symptom in 3 of these 4 categories: sensory, vasomotor, pseudomotor, motor. So with your feeling, your swell, temperature and color changes, swelling and sweating, or ability to move. So you're not face out moving, you may even have a tremor, you're weak. And at the time of the exam, you have at least one sign in 2 or more of the same categories. So if you meet this criteria, you get the diagnosis of CRPS. It's the Budapest criteria that everybody went, John can do it. So, whatever. So this is the current criteria for CRPS. So as you can see, it's not a disease per se. It's a syndrome. So this says nothing about how you got these things. It just says if you have. Okay. The incidence of CRPS is hard, because if you go through medical records at hospitals and you go to an emergency room and you do right after an injury, many people meet the criteria. But over time, so 28% following a wrist fracture meet the criteria for CRPS. But if you wait about a year, only 1% of those will still have it. So they heal. So why, the thing is, what was different about the group of people who, after an injury, developed the neuropathic pain criteria and did not heal, as opposed to the ones that did? Now this also implies that 72% broke their wrist and never even met the criteria for CRPS. They just broke it. They never got that swollen. They never got that red. They never got that pain. So we published this data in 2009. I was going to say a couple of years ago, but it's more than that now. We took about 1,000 CRPS patients, and we tried to get an idea of what is the progression, the history of CRPS, not by following one person for 30 years, but by taking 700 people who've had it for 1 year, 2 years, 3 years, 4 years, and see what was different about it. And the questionnaires, which some of you who saw Dr. Schwartzman had filled out, you probably filled out hundreds of questionnaires, not just for him, but for other people, showed that at least in the population here, and this is the same as populations throughout the United States, it is mostly women. It is not young women. It's mostly women in their 30s and 40s. And very few African Americans, Asians, or Hispanics. So it's mostly Caucasian women in their 30s and 40s. So I'm being a Hispanic male, I'm probably, got somewhere here, which is good. The reason for this is completely unknown, because the initiating event in about 80% of the cases is some kind of an injury, and another 11.5% is surgery, or a combination of the two. So most